opt-out basis, the Communities Care Survey. And that bill number is RS0557, also a recommendation out of the Mental Health Modernization and Reform Committee.
Committee, you've heard the introduction. Are there any objections? Without any objections, that bill will be introduced. Thank you,
Mr.
Kyle.
Chairman, have a good day.
Do we have any further, Travis?
Thank you, Mr. Chairman, members of the committee. I am Travis Lowe. Today, appearing on behalf of the Kansas Dental Hygienists Association. We respectfully request the introduction of a bill that would create a mid-level practitioner between a dental hygienist and a dentist known as the dental therapist. It is RS0636 on file with the revisor, 0636. Thank you very much.
Committee, you've heard the request for that bill introduction. Are there any objections to introduction of RS0636? Seeing none, that bill is introduced. Thank you, Travis. Do we have any other further bill introductions today? Seeing none, we will move on to our next item on the agenda, which is the Special Committee on Mental Health and Modernization Report.
Good morning, Mr. Chair. Can you hear me okay?
I can, Marisa. Thank you.
Okay. Good morning, Mr. Chair and committee. My name is Marisa Bayless, research analyst at KLRD. I staff this committee and I staff the Special Committee on Mental Health Modernization and Reform this past interim session. So I'm going to provide a very high-level overview of the Special Committee report, explain the structure and unique structure of this committee, review some of the higher level recommendations, and then highlight some major discussion points and themes that the Special Committee focused on. I'm actually just going to share my screen so we can have the report in front of us right now. This report should be available to you on the committee webpage. It's also available to you on the KLRD website. Just for a point of reference, especially if you've not worked with interim reports before. So when I mention this report, I'm speaking about this entire document. It is 150 pages long. So it contains a lot of great information, but we're going to really try and give you a very high level overview. We know you will likely have questions. There's a lot of great information in here, but KLRD is more than happy to try and help you walk through any other questions at a later time if you have any others. The Kansas Health Institute and working group members that you'll hear after me and tomorrow will be discussing the strategic framework. The strategic framework is an attachment within this report. So I just want to make sure that to denote that distinction. But first, as you can see at this report, you will be able to see all the members that were on this committee. You'll be able to see the study topic. This report will contain the gray box recommendations that probably look familiar to most of you, as well as give you an overview and summary of each meeting of the Special Committee. But first, I'll just walk through the study topic because I think it's pretty important, the breadth that this committee was directed to study. So the LCC directed this committee to analyze the state's behavioral health system to ensure that both inpatient and outpatient services are accessible in communities, review the capacity and current behavioral health workforce, study the availability and capacity of crisis centers and substance abuse facilities, assess the impact of recent changes to state policies on the treatment of individuals with behavioral health needs, and make recommendations on steps needed to make Kansas a nationwide leader on behavioral health delivery, specifically focusing on how Kansas should modernize its behavioral health system. The committee was then directed to solicit input from the following listed entities. This was done, and the committee also decided, because of the nature of this study topic, that asking the Kansas Health Institute, or KHI, to come in and help facilitate a working group process. So all these members and additional subject matter experts met outside of the regular special committee meeting. We also had all legislators on the committee also participate in these work groups. So you'll hear from them and the final work product of the strategic framework in just a bit. But the special committee formed 3 working groups: finance and sustainability, policy and treatment, and system capacity and transformation. So in this document, and one of the appendix pages, I'm going to point to the KLRD crosswalk. The crosswalk was kind of the basis of this committee and where we started. We know that there has been a lot of work from previous task force, from previous commissions regarding behavioral health. So we want to take a look at those and see what has been done, see what has been recommended, what has been implemented, what hasn't been implemented, and the gaps or barriers for implementation. So you'll see here, this actually became the setup. So we had 9 topics, 3 topics assigned to each working group. We took recommendations from previous task forces like the Child Welfare System Task Force, the Governor's Behavioral Health Services Planning Council, the Governor's Substance Use Disorders Task Force, the Mental Health Task Force, and the Crossover Youth Working Group. So we took all these recommendations that these previous committees had and we organized them into like topic areas to show some commonalities. At our first meeting, we had representatives from each of these organizations and groups come and speak, discuss the work that had been done in this committee. We then also heard representatives from KDADS, KDHE, DCF, and the Kansas Department of Education on their work regarding behavioral health and mental health, and then updates on these recommendations if they were directed towards them. Certain themes were repeated throughout the discussion of the special committee, and I just want to highlight a few. Pull it back up here real quick. The one major theme that popped up as in our discussion was telehealth. Due to the pandemic, certain telehealth codes were open, including those in the areas of behavioral health. We had representatives from a bunch of different areas come and speak about this. And report to the committee on how important telehealth is. Gaps like broadband access and technology as being barriers to expansion were discussed, but we did note that the gains that the frontier and rural areas have done in this area even prior to the COVID-19 pandemic. Another theme was integrated care. Integrated care is the idea of merging both behavioral health services and primary care services, trying to make these two entities seamlessly interact and communicate with each other. We heard a presentation about the Certified Community Behavioral Health Clinic model that Kyle actually just mentioned just a few minutes ago. And the CCBHC model is possible through enhancing certain Medicaid reimbursement rates. And the representatives discussed how Missouri has implemented this model throughout their state. Lastly, one of the major themes of discussion was data. The special committee was particularly focused on what kind of data the legislature has to utilize. Whether or not we collect certain data points, and if we do collect them, are they in a usable format? Can other agencies utilize that data if one agency collects it? And then can other outside entities also access that data? So using data as a decision-making tool was a very large theme that the committee discussed. And I just want to highlight some of the overall conclusions and recommendations. So the special committee wanted to note the opportunities for coordination and collaboration, and to also note the work that was going on simultaneously as this committee was working. Both the Kansas Criminal Justice Reform Commission and the Special Committee on Foster Care Oversight were also working at the same time this committee was, and also recommended certain behavioral health recommendations in their final reports. So just noting the opportunities for collaboration with those groups. The special committee wanted to note the contemporary issue of COVID-19 and behavioral health. While it may be too soon to draw actual data conclusions about the lasting impacts of the behavioral health system in Kansas due to COVID-19, the committee wanted to request state agencies and members of the working group and the legislature to continue to assess and monitor these impacts. Again, a final conclusion was data as a decision-making tool for modernization and reform. So the committee noted the identification of a variety of different data sources in the working group report and its committee process, and strongly encourages clear connected data systems and quality reporting to provide decision makers across the system with measurable and easily tracked results. The committee also wanted to recognize all the participants and expert information. You'll hear from some of these members shortly. We did have a ton of support from outside groups and individuals who took a lot of time out of their day to meet and to help work on the final product for this committee. The one request that this committee had was requesting that LCC and Legislature consider formation of a formal standing or joint committee to consider, address, and continue with the effort to address the longer-term goals and strategies incorporated in both this committee and the adopted working group's report. And then lastly, before I turn it over to KHI, the last conclusion or recommendation by the committee was adopting the strategic framework for modernizing the Kansas behavioral health system. So this was a working group report to the special committee. So at our last meetings in December, the working groups and KHI presented the strategic framework to the committee. The committee reviewed this and ratified the strategic framework. Some amendments were made. They were very minor and mostly clerical in nature, but the entire strategic framework was adopted. The strategic framework contains 45 high priority recommendations over a variety of behavioral health topics that are laid out in the crosswalk, and they're categorized for immediate action and strategic importance. So KHI and the working groups are going to review the strategic framework for this committee. But Mr. Chair, that's the end of my presentation and the overview of this report. I'd be happy to stand for questions, but I know we have a lot of people wanting to discuss, so I can wait if that's preferable.
Thank you, Marisa. And I think we will hold questions, committee, until after all the conferees had a chance to give their presentation, and that way we can see how the time goes. Marisa will be here tomorrow as well, so if you do have some questions for a conferee that we do not get to, please write them down and we'll make sure we get those asked. Marisa, thank you again for the presentation. And Carly Hushon, the senior analyst for Kansas Health Institute, is now going to give their part of their presentation.
Good morning, Chair Hildebrand, members of the committee. Can you all hear me okay?
Yes, we can. Thank you.
Very good. I'll jump in. So I want to first thank you all for the opportunity to provide some information on the working groups of the Special Committee on Mental Health Modernization and Reform. My name is Carly Houchin. I am a senior analyst at the Kansas Health Institute. And I'm joined here today by my colleague, Keena Shah, also a senior analyst at KHI. She will be available to help answer some questions and provide some more information on the data profile component of the strategic framework at the very end of our time together today. So as Marisa briefly said, KHI's role was providing facilitation and report development for the strategic framework that we will be going over over the course of today and tomorrow. So really this work started due to the interest from the Special Committee on Mental Health Modernization and Reform to put together a long-term strategic plan for modernizing the behavioral health system in Kansas. And so really they recognized to accomplish that goal, it was going to take pretty extensive collaboration. So they engaged dozens of experts through both the roundtable format and then establishing the working groups that Marisa described. And really there, I just wanted to highlight for the committee the involvement of the Kansas Department of Health and Environment, Department of Aging and Disability Services, as well as the Department for Children and Families. Each of those state agencies had representatives participate and contribute and quite extensively to the established working groups. Included with the testimony from KHI is a full list of working group members that's, I believe, labeled Attachment A. Additionally, as far as accomplishing the goal of this group, it was really only possible based on the 5 past collaborative efforts, again, that Marisa referenced. So just want to be sure to acknowledge all of the work of those past groups as well. So the working groups established included those related to the topics of finance and sustainability, policy and treatment, as well as system capacity and transformation. Will Warnes, the co-chair for Finance and Sustainability Working Group, will present in just a few minutes about the recommendations and other materials from that group. And then I believe the committee will hear from the Policy and Treatment and System Capacity and Transformation Working Group tomorrow. So then volunteers from each of those 3 working groups came together to form a subgroup to discuss the topic of telehealth. And again, we'll provide more information on that topic, I believe, in our time tomorrow as well. So the working groups met virtually for a combined total of 23 times, in addition to the 6 special committee meeting days. And this process is detailed in Figure 1 of the testimony materials from KHI. So the working groups made recommendations based on the topics assigned out to them by the special committee. So those recommendations and subsequently the strategic framework are organized around the topics of workforce, funding and accessibility, community engagement, prevention and education, treatment and recovery, special populations, data systems, interactions with the legal system and law enforcement, system transformation, and telehealth. So as we get into the working group report out, we'll go topic by topic to dive into those recommendations there. So throughout the strategic framework, high priority recommendations have been designated as either for immediate action or of strategic importance. So recommendations for immediate action are those that can be completed in the next 2 years, whereas recommendations of strategic importance are those that need to be initiated in the near term, but will be completed in the longer term. There's just more groundwork required related to those. Additionally included in the strategic framework is one high priority discussion item, which was to urge the special committee to consider the potential contributions of Medicaid expansion to a modernized behavioral health system. To arrive at the high priority items included in the strategic framework, the working groups utilized what we called a recommendation rubric to kind of guide discussion and subsequently scoring of each of the recommendations from the past collaborative efforts. This recommendation rubric is attached to the testimony from KHI as figure 2. So in addition to using this rubric to score those past recommendations, the working groups drafted new recommendations to address barriers or gaps as needed, and then also updated language from all of those past efforts to reflect the current understanding of each of the issues. After review of the scored recommendations, the working groups determined up to 5 high priority items for each of the 10 topics assigned out by the special committee, and that forms the body of the strategic framework report that you have in front of you today. So the strategic framework, the group throughout really talked about this as being considered a living document. Its purpose is to support ongoing collaboration between the many contributing partners in the behavioral health system, including government agencies and the state legislature as well. This final strategic framework at maybe the highest level has 3 key components. So it includes vision statements for modernization as it relates to each of the 10 identified topics. So when we talk about workforce, what does it mean to have modernized behavioral health workforce? What does that look like? So there's vision statements included related to each of the 10 topics there. Secondly, and really the bulk of the report are the high priority items or recommendations. There's a table as it relates to each of those recommendations that provides contextual information and some of the details of the working group discussion as it relates to that item. And then lastly, the report includes a data profile to provide a snapshot of the behavioral health system in the state. So as Marisa highlighted, really across meetings of the special committee, they discuss the value of using data to closely monitor outcomes related to the behavioral health system. These data could provide the information needed to ensure that Kansas is on track to achieve a high quality modernized behavioral health system, and that any funds expended towards this end have both the appropriate and intended impact. The data presented in the data profile in the strategic framework provide a snapshot of the many overlapping systems within the behavioral health system, but want to highlight that this only includes a subset of the wide range of data that are available from the state agencies and others. Please note as you're reviewing that data profile, the impact of COVID-19 on the behavioral health system is not yet reflected in those data or proposed measures in this report. But again, really considering this report a living document and think that specific measures to that end of understanding those impacts could be added in subsequent years as they become available. So I'll stop there. I want to thank the committee again for this opportunity to provide background information about this report. I will be happy to stand for questions at the appropriate time, but I think perhaps we're ready to hear from our first working group, Bill Warrens.
Thank you very much for your presentation, and we will now move to Will Warrens. He is the Medical Director for Behavioral Health, and I believe he's with the Sunflower Health Plan. So, Will, thank you for
Yes.
coming today.
Thank you, Mr. Chairman and members of the committee. My name is Dr. Will Warrens, and I served as co-chair on the Finance and Sustainability Working Group of the Mental Health Modernization and Reform Committee, and represent the group's work here today, along with Greg Hennon, who's Executive Director of Four County Community Mental Health Center, and was also a co-chair on the working group. The working group addressed 3 topics. The first of which was workforce. In the workforce topic, we advanced 5 recommendations as highest priority, with 3 highlighted for immediate action and 2 for strategic importance. Sorry if I move at a pretty fast click here, but I think we're about, maybe about a minute per topic, that we have to discuss them. So I'm going to fly pretty fast. So in the workforce topic, recommendation 1.1 for immediate action to reduce the number of clinical supervision hours required for master's level behavioral health clinicians from 4,000 to 3,000. This was originally proposed by the Committee of Alcohol and Other Drug Abuse of the Governor's Behavioral Health Services Planning Council. This has already been enacted in other areas of mental health treatment in Kansas, and was found to be effective in decreasing barriers to getting additional workforce members in those areas. And so we felt like it was something we could get behind. It also brings Kansas in line with some neighboring states that have a similar number of supervision hours. Recommendation 1.2, access to psychiatry services. This talk initially started out as talking about the potential for a program to support the recruitment and increase the number of psychiatrists in the state of Kansas. However, the working group did acknowledge that there are programs in the state of Kansas, such as the National Health Service Corps, the Kansas State Loan Repayment Program, and we did not want to start proposing the structure for an additional program without requiring first a study to be conducted by KDHE on the programs that are in place, which might better inform us moving forward on what a program might look like to better recruit psychiatrists for the state of Kansas. This was also flagged for immediate action. Recommendation 1.3, provider medication-assisted training. This was flagged for immediate action to increase the capacity and access to medication-assisted treatment in Kansas. Medication-assisted treatment is when someone is suffering from a substance use disorder, and while there are many highly, highly valuable therapies for that disorder, this particularly addresses medications that can help patients with their substance use disorder symptoms. This was originally proposed by the Governor's Substance Use Disorders Task Force, and this one already has a lot of features to it that is in play in Kansas and trying to increase access to medication-assisted training, and we want to support that for funding going forward. Recommendation 1.4, a workforce investment plan. This was the first recommendation we're reviewing that is of strategic importance. Strategic importance means that it can be initiated immediately, but we do not expect that it would be completed within the next 2+ years. But this one was a proposal initially recommended by the Child Welfare System Task Force, and it is to make a long-term investment plan for the behavioral health system, increasing funding for training, recruitment, retention, and support to effectively attract and retain high-quality staff, including developing a clear career ladder for clinicians through the development of associate levels practitioner role, and this recommendation is interesting, and that is the 2-part recommendation. It also incorporated in it is to take action to increase workforce diversity within the behavioral health workforce of Kansas. And let's see. I don't think there's much more to talk about in that recommendation. Recommendation 1.5, family engagement practices. This is the final recommendation in the subject of workforce, and this is of strategic importance. This was originally developed by the Children's Subcommittee of the Governor's Behavioral Health Services Planning Council. This recommendation, in looking at the recommendations from the Children's Subcommittee, the Children's Subcommittee released a wide variety of recommendations that all were designed to increase families' involvement in children's mental health treatment. Most mental health providers would agree that evidence-based practices steer us towards the inclusion of caregivers in the child's treatment. And so there's a wide variety of recommendations, including adopting those evidence-based practices in treatment in Kansas that include parents and other caregivers in the child's treatment, and to ensure that clinics are family friendly for this type of treatment, as well as a wide variety of other recommendations geared towards this topic. So the second subject that we reviewed was that of funding and accessibility. So the first, we advanced 5 high priority recommendations out of this subject, all highlighted for immediate action, as well as 1 high priority discussion item, which we will get to, that's Medicaid expansion. So recommendation 2.1, certified community behavioral health clinic model. This is the committee's, the working group's attempt to recommend transitioning to a model of care for the community mental health center system that would increase the focus on outcomes and quality measures while having an increased rate of reimbursement along the structure of the Excellence in Mental Health Act of 2014. One part of this recommendation is for us to advocate for Kansas's inclusion in the Excellence in Mental Health Act, but barring that, to explore possible state plan amendments or changes to the 1115 waiver to allow interested providers to gain access to the certified community behavioral health clinic model. This one is flagged for immediate action, but it would be a very strategic and difficult to accomplish recommendation, but one that was highly recommended from the working group. Recommendation 2.2, address inpatient capacity. This one was flagged for immediate action, and this one, to implement and fund a comprehensive plan to address voluntary and involuntary hospital inpatient capacity needs. And I think one of the big reasons for this is really to try to decrease the amount of behavioral health treatment that's being done. It's the best treatment that can be provided, but it's being done in emergency rooms and in non-psychiatric clinics while we wait for psychiatric beds. I think that the working group acknowledges that KDADs and other state departments are actively working on this issue, and there actually is a large program that is coming into play in 2021 called the State Institutional Alternative Program that is trying to address this. So work has already begun on this issue, but this was felt to be of high priority for the working group. Recommendation 2.3, reimbursement rate increase and review. This one was flagged for immediate action. In our committee, Keith Rickard, Executive Director of the Guidance Center, presented on October 30th about some of the more global strategic funding concerns for the CMHC system in Kansas, and some of those have to do with the structural logic with which funds are applied to the CMHC system. And so this is a two-part recommendation. Coming out of the CMHC system and their financial crisis, there was a recommendation for a 10 to 15% increase in reimbursement rates for behavioral health services. It was noted in the conversation that there has not been a increase in reimbursement rates for the last 20 years. But then also to establish a working group to look at specifically the way the uninsured and Medicaid populations are funded in the state of Kansas for the behavioral health system, and to see if there can be improvements made on the structural logic of some of that funding forward. Recommendation 2.4. This one is regarding suicide prevention. This was flagged for immediate action. Recommendation initially proposed by the Prevention Subcommittee of the Governor's Behavioral Health Services Planning Council. This is trying to acknowledge the fact that suicide rates have increased in Kansas in recent years. And there appear to be some particularly vulnerable populations such as veterans and children and adolescents. The group also acknowledged that there are a lot of proposals that are either have been proposed and not funded, or have been enacted by various state agencies and just need ongoing funding to continue the work that they are doing on these topics. And this recommendation was in support of that work. Recommendation 2.5, Problem Gambling and Other Addictions Fund. This one was flagged for immediate action. This was initially recommended by the Committee on Alcohol and Other Drug Abuse of the Governor's Behavioral Health Services Planning Council. I'm not as knowledgeable as some of the legislators that were on our working group, but there was conversation that initially there was lottery gaming revenues that was flagged for addiction treatment that might have been appropriated in a more broad fashion. And the recommendation was to rededicate that 2% to addiction treatment, which was what members of the working committee felt was the intended purpose of those funds. So that brings us to a unique area, and that was Medicaid expansion. There are enough effects of Medicaid expansion on mental health in Kansas that the working group felt like it should be included and some of those effects noted. But we could not advance a recommendation either for or against Medicaid expansion because there were sophisticated thoughts and arguments on both sides of that topic. And so we felt that we should include it, but have a unique designation for it, which is a high priority discussion item. And that was kind of the balance we came to there. Our third topic that we discussed was community engagement. We advanced 4 high priority recommendations, 2 highlighted for immediate action and 2 for strategic importance. Recommendation 3.1, crisis intervention centers. Utilize state funds to support the expansion of crisis intervention centers as defined by state statute around the state. So this is another topic that the working group fully understands that there has been good work done. There has been crisis intervention centers established throughout the state. They rely on multiple varied funding streams, and I think some of the funding for those crisis centers, we would like to ensure, how do I say this? They are funded in an ongoing fashion. We also know that there is there are thoughts to adapt our crisis services and take them maybe even to the next level of mobile crisis services. And the working group was recommending to support these efforts in crisis intervention across the state of Kansas. recommendation 3.2, IPS community engagement. This was originally proposed by the vocational subcommittee of the Governor's Behavioral Health Services Planning Council. This is to support the implementation and funding of an evidence-based supported employment program and to create opportunities for assertive outreach and engagement for consumers and families. And in the field of behavioral health, in the 21st century, there is something called social determinants of health, and that is an understanding that it's more than the neurochemicals in the brain or biological aspects of a condition that someone may be suffering with. It is also the environment and community in which they live and addressing some of the barriers to their wellness. And that is the spirit in which this recommendation is advanced from the working group to help with employment.
Dr. Warren, I appreciate your in-depthness on these recommendations, but time is becoming an issue. We still have 2 more conferees after you. Would you be able to just give a brief summary of each one so we can make sure we have
Sure. Mr. Chairman, we're almost done. Recommendation 3.3, foster homes of strategic importance, investing in foster home recruitment and retention. And then recommendation 3.4, community-based liaison. This is an individual to help individuals upon reentry from the justice system. And this is a position that has been designated for CMHCs, but has not been funded to date. And the recommendation would be to fund that position for ongoing use in Kansas. So that is what I have. So I will pause for any questions.
Thank you, Doctor. We are going to hold questions until after all the conferees have had a chance to speak. So if you can, will you be able to hang on until for about another 15 minutes or so?
I will, Mr. Chairman.
Thank you. Committee will next hear from Greg Hennon. He is the Executive Director for Ford County Mental Health. Thank you, Greg.
Yes, actually, Dr. Warren's presented our testimony. I was co-chair of that committee, and everything that I would have to report, he has already spoken to. I was just here to respond to questions in support of Will's testimony.
Greg, thank you. Committee will next move to Hina Shah.
Good morning, committee. Can you hear me?
We can, thank you.
Terrific. So thank you, Chair Hildebrand and members of the committee. My name is Hina Shah, and I'm a senior analyst at KHS. Thank you again for this opportunity to discuss this data profile and the strategic framework section of the report. I'd like to direct the committee members to turn to page 43 of the report. And as my colleague Carly Houchin discussed earlier, the special committee wanted to make sure the value of using data was really implemented into this report. And so they wanted to make sure data was closely monitoring outcomes related to the behavioral health system and ensure that Kansas is on track to achieve a high quality modernized behavioral health system, and to see if the implementation of the high priority recommendations would have the appropriate impact. So the data profile that you'll see starting on page 44 is like the 10,000-foot view, and it would provide a systemic assessment or a snapshot of the state's behavioral health system. Keep in mind that it includes only a subset of a wide range of data that are available. So in the future, this could be amended to include measures related to COVID-19's impact or perhaps substance use disorders. So it can be modified over time as this is a living document. So who developed this data profile? State agency staff who served on the working groups, as well as staff from other agencies, were invited based on, you know, how Dr. Warren's was going through each recommendation. There was this little box that said key collaborators. So if there was an agency that was in that box, they contributed to this data profile or the potential measures for any of those high priority recommendations. So this included staff from the Kansas Department of Aging and Disability Services, Department of Health and Environment, the Kansas Department for Children and Families, Kansas Department of Corrections, Kansas Department of Education, and also the Kansas Attorney General's office. So now we're going to turn to the top of page 44. And the first set of measures that you see there are process measures. So this is telling you if we have many of these high priority recommendations implemented, what should we be seeing here? Keep in mind that if there is an asterisk there, the data are reportable by the state agency. So if you would like that information, to ask them to report it. I will say that at this point, I think crisis intervention centers, there are none that are operational in the state, but a member from KDADS could correct me if I'm wrong. So that is the first set. As you see, it indicates how many mental health professional shortage areas are there. And then, as I said, the other counties that have these support services available. The next set are outcome measures. And so for this is a variety of measures that are really giving you that systemic assessment. What's provided here is kind of the most current year of data. So remember, data sometimes lags, and so that's in parentheses. Then the previous year of data for comparison, and also national data so that you can see kind of the current year and previous year for comparison. Keep in mind that no statistical tests have been done, so significance isn't presented here, but it can still give you an idea of what Kansas looks like compared to the nation. And so the uninsured rates are provided for both adults and children. Also, there was attention to suicide with the increasing rates, so the statewide adjusted mortality rate for suicide. When looking at youth, looking at clinical predictors for depression, and then also looking at children who have a condition who are actually receiving treatment as well. So not only looking at, you know, if what's prevalent, but also who's receiving treatment. Now, individuals with SPMI, for those who aren't familiar with that acronym, that means severe and persistent mental illness. Those that have been enrolled in supportive housing and have not had an ER or a psych admission in the last 12 months. And then also having supportive employment. So really thinking about those constructs, concrete supports, and making sure that those are in place. And then the last one in that set is percent of individuals with inpatient psychiatric stay in the previous year that have returned to and remain in the community without additional hospitalizations. So the reason there's a double asterisk there is that it means that the measure could be reported in the future, but it really needs the implementation of certain recommendations related to like data interoperability and higher rates of participation in like health information exchanges. So many of those high priority recommendations would have to be implemented to be able to report that measure. So that ends kind of the outcome measures. Next, there's the Mental Health in America rankings are presented. And before we dive into those, just keep in mind that rankings are based on a point estimate or composite estimate from the most recent data that's available. And sometimes it's multiple years of data. So for Kansas, it's multiple years pulled together. And so while rankings can convey where Kansas is in comparison to other states, they might not show direct improvements. And to really see these improvements, you'd have to examine point estimates and go back to like the data that's supporting these rankings. Also, they say to compare to states that are in similar size. So what's reported here is measures for Kansas, and it's from 2021 back to 2015, and 2015 is your baseline year. So again, you have rankings for kind of overall for adult and youth, and then also rankings for adults with mental illness who report unmet needs, and then youth with at least one depressive measure. One thing that I will say is the overall ranking is comprised of 15 measures, and this includes both adults and youth. And so these are around mental health issues, substance use issues, access to insurance, access to adequate insurance, as well as access to and barriers to accessing mental health care. And so if you're ranked 1 to 13, this indicates lower prevalence of mental illness and higher rates of access. And if you're ranked 39 to 51, this means lower rates, higher prevalence of mental illness and lower rates of access. And again, data, like I said, there is a lag. So the 2021 report, the indicators are data from 2017 and 2018, while the 2020 report has indicators from 2016 and 2017. And so if you want more information, you can definitely go to their website and see others. The special committee also asked for an in-depth analysis for the adults with mental illness who report unmet needs, and KLRD could definitely send that to the committee if requested. So that is the data profile in a snapshot. And then again, as Dr. Warrens was presenting those high priority recommendations, there was that little box that says measures in there. And so there are some select process and outcome measures that could monitor the impact of those high priority recommendations if implemented. And that is all I have, and I'm happy to stand for questions.
And thank you very much for your presentation. Committee, we are going to open it up for questions. We do have a few minutes, and I do have a question and then a comment. The first question is for Dr. Warrens. Doctor, are you available?
Yes, I'm here, Mr. Chairman.
Okay. On recommendation 2.2 for more bed space, do you know if our current governor still has a moratorium on Larned and Osawatomie? If so, what is the bed count that that moratorium is on each facility, and what is that impact having on accessibility to that? And then the last part of that question is, do we know when that moratorium will be lifted or if it's going to be lifted? Thank you.
I believe I can partially answer your question, Mr. Chairman. I do not have access to the exact bed count of what we're looking at right now. My understanding, though, is it is still below pre-moratorium levels. So the moratorium would still be in place, I guess, from that aspect. KDADS is working on a plan right now to begin opening new beds for acute mental health treatment. They're going to be structured a little bit differently, called the State Institutional Alternative Program. And these will be coming out in a stepwise fashion because they will be providers from across the state will be able to apply to be part of this program and designate a certain number of beds. And so the hope is that this not only will get us back to pre-moratorium levels of beds, but that this will also allow those beds to be regionally scattered throughout Kansas, so more accessible to members throughout Kansas. And the hope is that in spring of 2021, the first of those contracts are going to start being released. I think that's as specific as I know as far as when the moratorium's, going to be lifted. I think it's just a matter of finding enough of those contracts to find enough beds to get us back to pre-moratorium levels.
Thank you, Doctor. And then just one thing I wanted to comment we have a lot of new committee members, and it has reference to what you had mentioned in 2.5, the problem gaming fund. For those of you that aren't aware, that is, you guys have all heard of the Bank of KDOT, sweeps coming out of the Bank of KDOT. Well, this would be considered the Bank of Problem Gambling Fund. Unfortunately, Kansas has decided to balance their fiscally irresponsible budgets, that's my opinion, on sweeping funds that they have no business sweeping to balance a budget. So for you committee members that aren't aware, that's what he was talking about in 2.5. So at this point, committee members, do we have any other questions for any of the conferees? Senator Thompson.
Thank you, Mr. Chairman. For Hina, is that how it's pronounced? Regarding the mental health rankings in Kansas, and if I read this correctly, we are the worst in the nation with adults with mental illness who report unmet needs, but yet we have a number 29 ranking overall. That seems like a conflict. I would think that our overall ranking would be even lower, considering the unmet needs. And is that related to COVID?
So I will answer those in reverse order, if that's okay. It is not related to COVID because the data is from 2017, 2018 for that ranking. And then for the overall rankings, this is a composite of about 15 different measures in there. And so the adults with mental illness who report unmet needs are just one of the 15 measures. So that's another thing to keep in mind. If requested from KLRD, there is a memo that will explain adults with mental illness who report unmet needs. What we did is we went back to 2021 to 2015 and actually looked at the point estimate. And the way they do rankings is they look at your point estimate and then they just rank all the states. And so over time, it is, I mean, everyone's estimate is kind of getting a little worse, but in the grand scheme of things, we were just worse that year, and it kind of fluctuates here and there as well. So I would direct you to ask for that memo, and I'm happy to respond to more questions after you have a chance to review it.
Thank you. Thank you very much. Thank you, Mr. Chair.
Senator Baumgartner.
Thank you, Mr. Chair. First, I'd like a shout out to Carly, Lewisburg High School graduate. Glad to hear your presentation today. My questions are for Dr. Warnes. So I'll start with the workforce investment plan. You made reference to an associate's degree. Are there any community colleges in the state right now that are offering Associate of Science or Associate of Arts degree in that particular area?
Thank you. I'm not aware whether there are or not, but I do know that exploring community colleges was a specific point discussed by the working group of importance to see if they could be enlisted to help in the education and development of that position.
Education Committee yesterday had a hearing on the Promise Act, and one of the areas, instructional areas, happens to be in healthcare, which would include the mental health care. So hopefully you might be able to join on with regard to our push for getting that Promise Act enacted into law, because we think that that would be very instrumental for high school graduates and those that are 21 years old or older that are needing job training and wanting jobs. We think that would be crucial. My next question has to do with, it was the slide after 2.2, and it made mention of a proviso for KDHE. That KDHE was going to be looking into, see exactly what it was that KDHE was looking into.
Is this in reference to recommendation 2.3 reimbursement rate increase in review?
That's the one.
Okay.
So has KDHE done any research on that?
I believe that individuals, at the state are aware of some issues with funding to the CMHC system. There hasn't been it has come out in various reports, like the NRI report and some other reports over the last few years, but I don't think there has been a review specifically on the topic of the some of these issues, such as the rising level of uninsured presenting to CMHC systems, the static levels of state grant funds to support those individuals, and then how the fee structure and the Medicaid reimbursement structure is designed in an increasingly strained fashion to try to support the Medicaid and uninsured populations.
Mr. Chair, I think one of the problems that we have, and part of the testimony today, was that there hadn't been changes in the fee structure for 20 years. And yet at no point in time has any of our agencies or any of our groups come with actual research or information as to what would be the economic as well as what would be the budgetary impact of that. And while the issues are real, as far as limited service within our state, there isn't enough factual research-based data to make what would be long-term implication decisions. And groups are going to need to, including KDHE, are going to need to get that information to legislators for us to make factual decisions or decisions based on fact. I just have two other observations, not so much a question, but with the conversation about the crisis intervention centers. I haven't met anyone that's been opposed to that, but the Corrections and Juvenile Justice Joint Committee has met 3 years in a row, and for 3 years in a row, there has been $2 million budgeted for such interventions services, but the RFP has never had a successful applicant because it's been viewed as so cumbersome and not really fitting in with what the needs are for the communities that are wanting to partner and provide community funding as well for those intervention centers. So again, we have 2 million, 2 million, 2 million sitting there not being used. And my last comment has to do with foster homes. We know that foster homes in our state have been problematic. In fact, there were severe substandard issues that were identified when the federal government came and evaluated our foster homes. So I would be hesitant to expand foster homes because they haven't risen to the level that would be appropriate for our most vulnerable children. Thank you, Mr. Chair.
Thank you, Senator Baumgartner. One quick last question for Senator Petty. And committee, just a quick reminder, we will adjourn right after her question is answered, but we do have the joint meeting with the House from noon to 1 and 112 North.
Thank you. I think the recommendation on foster homes had to do with recruitment of foster homes, how important that is. And I would just suggest that committee members think about having this report run off by your assistant, because it is pretty comprehensive and it's hard to follow through on the line.
Thank you, Senator Petty. Thank you, committee members. We are adjourned. Thank you.